Hello, this is Dr. Grande. Today's question is, what are some of the criticisms of cognitive therapy? Now, in some previous videos, I've talked about a lot of the features and characteristics of cognitive therapy, including many of the strengths. And here I'll be talking about some of the limitations. Now, some of these limitations I'm going to mention really apply specifically to cognitive therapy as developed by Aaron Beck, and some of these limitations apply to cognitive therapy and cognitive behavioral therapy in general. So cognitive therapy, or CT, is really just a type of cognitive behavioral therapy, or CBT. So in terms of the limitations, so when looking at cognitive therapy, the first limitation that comes to mind is that in cognitive therapy, cognitive distortions, in a sense, cause symptoms. So irrational thinking, illogical thinking, to some extent dysfunctional thinking, results in depression or anxiety. This isn't really necessarily consistent with what we see in research. It could be that, in fact, mental health disorders cause illogical thinking and irrational thinking in some cases. We do know that it appears that cognitive distortions, irrational thinking, can lead to symptoms. So I think it's reasonable to conclude that the causality here works both ways. Mental health disorders can cause irrational thinking, and irrational thinking can cause symptoms. Still, though, I view it as a limitation of this model. Another problem with cognitive therapy is it tends to avoid legitimate problems through the mechanism of reframing, the technique of reframing. So sometimes when someone is depressed or anxious or has a variety of other symptoms, there is a legitimate life stressor that could be causing those symptoms. And in cognitive therapy, cognitive therapists look to reframe that. And sometimes that really comes up with a conceptualization of the problem that isn't true. It's sugarcoating, in essence, the real problem. It's having somebody look at the situation differently, which is different than saying, look at the situation accurately. So there's a danger here to minimize or just sidestep legitimate stressors. Another criticism of cognitive therapy is in the cognitive model. Core beliefs lead to intermediate beliefs. Intermediate beliefs are attitudes, rules, expectations, and assumptions that a client may have. These intermediate beliefs combine with stressors. This results in an automatic thought that leads to a reaction. And oftentimes we could think of this reaction as being one or more symptoms. The problem here is that this assumes a stressor, to some degree, causes mental health symptoms. And here, if we look at the research, we see that a lot of different disorders, including some depressive disorders and anxiety disorders, don't always have a clear stressor attached to them. Sometimes what happens is someone feels the symptoms and then looks around and sees what's going on and attaches whatever's going on to that symptom. So they believe that certain life circumstances may be causing the symptom, but that may not be the cause. Stressors certainly sometimes do cause depressive and anxiety symptoms, but not always. In the cognitive model, there's always a stressor to blame somewhere, and that just doesn't line up with what we know. Also, with this limitation, there's a tendency, if a cognitive therapist isn't careful, to blame the client, meaning the client must not be thinking correctly, that's why they have symptoms. And that's really what the cognitive model says. So it's dismissive of the biological and genetic component, and also dismissive of unknown factors. Again, some of these symptoms don't have a clear stressor. We would refer to these as idiopathic, meaning we don't know what causes them. So if a cognitive therapist isn't careful, this seems like they're saying to a client that they're just not thinking correctly about a situation, and this is what's leading to symptoms, and again, we know that's not true. Certainly, some of the time, irrational and illogical thinking can lead to symptoms, but not all the time. Another limitation of cognitive therapy is it's too highly structured. And that can come off as cold or mechanistic. And I've heard this criticism quite a bit. I think this is a fair criticism. I would say this is one of those criticisms where a cognitive therapist could modify the therapy a bit to make it more personable, maybe using more person-centered strategies and only using the cognitive strategies sparingly, as not to come off as high pressure or too mechanical. Another limitation of cognitive therapy is that for this therapy to work, using the cognitive model and the different techniques, insight is really crucial. And with a number of mental health disorders, insight can be compromised. Now, to be fair, this is a criticism that I have of a number of therapeutic modalities, not just cognitive therapy. There seems to be a bias, in a sense, with these models that they would work much better for individuals who have more insight. Now, of course, you could make the argument that if someone has more insight, they're more likely to improve, they have more tools available to improve, and that may be true. But either way, we need to have modalities that work with a wide range of individuals, and cognitive therapy doesn't always seem to fit that bill. Another criticism we see is that cognitive therapy can appear from the client's perspective to be boring and narrow. Meaning a lot of times when people come to therapy, they do want to talk about relationships, what's going on at work, what's going on in the family, childhood experiences. And cognitive therapy really doesn't have a lot of room for that. It's very centered on irrational and rational thinking, and to some extent, behaviorism, behavioral strategies. So it can seem a little dull and maybe too focused. My last criticism of cognitive therapy is really a comparison of cognitive therapy and behavioral therapy. So a modality that takes just the behavioral component of CBT. What we know from research is that in some cases with some mental health disorders, behavioral therapy alone has been shown to be equally effective as cognitive therapy. Meaning CBT may not really need the cognitive component in many cases to be effective. The behavioral component may be the active ingredient, so to speak, in cognitive behavioral therapy. I hope you found this description of the criticisms of cognitive therapy to be interesting. Thanks for watching.